Hi, I'm Peter Soukas. I am the Director of Vascular Medicine and the Director of the Brown Vascular and Endovascular Medicine Fellowship Program at the Miriam Rhode Island Hospitals and the Brown Medical School in Providence. I have the great privilege today of chatting with Dr. Sameh Sayfo, who runs the Interventional Fellowship Program in Vascular Medicine at Baylor Scott White in Plano, Texas. We're going to be talking about new generation IVL technology, specifically introducing E8. So I'm going to turn it over now, and I'm going to ask Dr. Sayfo to show us some few clinical cases and really to illustrate some of the advantages of the new device compared to the earlier devices. So Sam, show us some interesting cases.
Absolutely. Thank you so much. Thank you for the introduction. So yeah, as Dr. Soukas really kind of prepped me for those, and he mentioned many of the really good characteristic of this device that's helping us. We all, both of us had a lot of experience with the S4 and the M5 Plus. So having an E8 and showing a couple of the cases why we think this is going to change the practice. So I'm going to summarize it with 4 points. It's a longer shaft, more emitter, it's easier to deliver, and of course has more cycles. So start with the case is a 84-year-old gentleman who had a non-healing wound, had a non-compressible ABI, a vessel with an ABI of 1.8, but have a significantly abnormal TBI. Angiogram which showed a two-vessel runoff with a very disease below the knee. This is his wound. You can see two different wounds in this gentleman. Clearly, this is a very practical case where you see this patient really don't seek attention till later on in life, and this is what we're dealing with. You can see a long below the knee disease, very calcified vessel. It's important to have a technology that we're able to cross those. I mean, this is when you look at it, traditionally those vessels are between 2.5 to 4.0 millimeter in diameter, but when they're diseased, it becomes very hard to deliver. Again, likely this patient did not have an NESFA or popliteal disease that we had to deal with. We after being part of multiple below-the-knee trials, we really learned that IVUS is really crucial in those below-the-knee disease vessels. And treating them, in this case, if you look at the pre-360 calcified vessel, post-IVL, you see a couple of cracks in the calcium, and this after final therapy with a long balloon angioplasty, larger diameter, and a really nice acute lumen gain. This is our final angiogram post. And again, when we have those kind of severely diseased vessels, you always worry about disemboliization. The safety profile of IVL or Shockwave has been, from the beginning, from PAD 3 until now, it's very obvious. And for this case, we use a 3x80 E8 balloon. This is another case. Some of the difficulties for below-the-knee vessel treatment is when you have this sharp angle, and we see it a lot in the AT vessel, a very sharp angle, disease, calcified vessel. This is a very similar case, 75-year-old male with a non-healing wound. Actually, there was an attempt to fix that AT before. They were not able to wire it, and because of that, they were not able to deliver any therapy. We were able to cross it with a wire escalation, and we delivered our 4x80 E8 based on IVUS, and we had a beautiful result.
So, Sam, let's talk about, from a practical standpoint, really in comparing S4 and M5 to E8, because a lot of the people who are going to be watching this have familiarity with those devices. They're tried and true, and they've been really breakthrough products for these last several years now. So in your mind, how do you shift from S4, M5 Plus to E8? What are the characteristics of E8 that you think maybe allow for moving to the new platform? What do you see as the chief advantages in terms of throughput through the lab and also with regards to reach?
No, definitely. I think if you look at the portfolio for M5 Plus and S4, when you start going on a smaller size balloon, you have to switch from the M5 Plus to S4. So in the lab, you have to have two balloons, two systems. Where here you can have E8 is from 2.5 all the way to up to 6, which basically kind of overlap both of those. And it will be easier for us when we keep those balloons in the cath lab to have one device that covers both below the knee and above the knee. You mentioned something previously, and I think it's very important. We rarely find those SFA discrete lesion anymore. It's always a long, very, very long, 30 centimeter, heavily calcified lesions. And with the E8, you're able to deliver energy and treat up to 36 centimeter, which is very long lesion. And sometimes you want to focus your energy on more of the mid SFA where there's a big rock, so you have enough energy to deliver there. And the last thing is below the knee. Below the knee disease has become a frontline therapy nowadays with those very ill patient, with a very CLI patient, done healing wound. And we always had challenges delivering devices all the way below the knee, the tortuosity, the calcification, the size of the vessel. E8, because the hydrophilic coating with the 45 centimeter is very helpful. From a practical perspective, we've been very successful delivering those.
Yeah, I think one of the major advantages is that of that hydrophilic coating, the enhanced crossability. Think about how many times you had to take out, maybe even more, sometimes 2 or even 3 balloons to pre-dilate, and then in order to then be able to deliver your definitive IVL treatment catheter. So in terms of time saved and also money saved, right? Because you're not using 2 or 3 pre-dil balloons, the ability to potentially do an entire case with just 1 balloon is obviously very, very gratifying. And let's face it, from a cath lab budget standpoint, the ability to eliminate pre and post-dil balloons, the ability to potentially treat a 40 centimeter segment with just 1 balloon as opposed to 2 or 3 IVL balloons. I mean, that really does translate into significant cost savings. And then, of course, we are dealing with a lot of patients now who have advanced kidney disease, who have renal insufficiency, who are having more and more calcific disease, particularly in the below knee vessels. And one of the biggest frustrations that I've had is getting a wire across the lesion and then not being able to get a balloon to follow. So maybe you could talk a little bit about the differences you've noticed with E8 in terms of its pushability and crossability, even compared to our predicate S4 device.
Yeah, I mean, as you mentioned before, you start talking about below the knee and calcified lesions. You have 2 advantages with the E8. One, as you mentioned, pushability and deliverability is much easier. It's very smooth. It's very hydrophilic. Are you going to have the cases every once in a while where you have to pre-dilate? Of course you can.
Sure.
You have. But as you said, nothing more frustrating than you are able to get a wire through and you know you're a true lumen, but nothing crossing. No microcatheter, nothing crossing. Even the balloon that we tried to do, they're not crossing. E8 has been, very deliverable. It was fascinating how slick that balloon is. In majority of the cases, it takes that curve of the AT very nicely. Mm-hmm. With that, I was always worried because it's an 80 millimeter. Are we going to have to deal with that sharp AT bend? Are we not going to be able to deliver it? The other thing is, remember, some of them are 5 French compatible, up to 4 millimeter in diameter on the E8 are 5 French compatible. So there's a lot of operator out there who does a lot of pedal work. And I think having a capability of putting a 5 French sheet and delivering, an IVL through your pedal, I think that's very helpful, which we didn't have that before.
Yeah, particularly, for example, in patients who've had a prior EVAR or who maybe have had kissing stents into the aortic bifurcation where an up and over approach is not possible.
Definitely.
And we all hate to come from the brachial because there's much higher vascular complication rate. So the ability to come from the wrist, or as you're alluding to, coming from the ankle is really incredibly helpful. But let's talk about thoroughness of vessel prep. I think that there are some operators, because they're so worried about restricting their IVL use to just 1 balloon, especially in a coral reef, 30, 40 centimeter SFA CTO. That's a situation where legitimately you probably are going to need more pulses. And more often than not, you might need to use 2 balloons. So maybe you could speak about the 400 pulses and the potential to maybe get away with just a single balloon.
Yeah, I mean, the nice thing about it, it's still pulsing 2 pulses per second. So it doesn't take a longer period of time. Like, I think we got used to the privilege of M5 Plus when it's really fast, where
Right.
previously now, the other day I pulled up I was doing, I think, an S4, and I pulled an S4, and I was like, "Ah, this is too slow." So,
Sure.
so the E8 is you do 2 pulses per second. You have 400 pulses. You're really able to deliver energy throughout the SFA, no matter how calcified and diseased it is. And of course, at the end, I will always keep a couple of cycles to the end where I can say, okay, I've finished the whole SFA. Maybe there's a couple of spots will require a little bit more energy, and I go back and deliver energy. Are we going to have to deal with cases where you have to open 2 balloons? Possibly, but I think that chance has become very low probability with the E8 because of the 400 pulses.
What's been your experience having the luxury of now 400 pulses? Do you find yourself using all 400, or are you basically just seeing if the waste on the balloon goes away and then sort of moving on?
Yeah, no, I mean, the case I just showed, the last case from the radial, we did 160 pulses. I don't think we delivered the whole thing, because I think when we start with the low inflation, get some contrast there in the dog boning, and we deliver energy. And as everybody knows, it's really important to that when you deliver those energy, you're gonna have to de-air and make sure you have no bubbles in the system.
Right.
But we usually, whenever we get that dog boning is gone, I may deliver 1 or 2 more cycles, and then usually I don't have to put the whole thing of the 400 cycles. I think at the 400 pulses, I don't think there's a need for all of them, but if you have a long, very calcified vessel, I think you already paid for it, so we're not using it.
You know, my joke is, you wouldn't leave a half a beer. Why not use all your
That's
pulses?
exactly right.
And final question, Sam. Now with the availability of the 150 centimeter shaft, how far on average do you think you can reach with E8 coming from the radial approach?
So in my practice, I use right radial on most of the cases, especially with the development of radial to peripheral sheath and catheter. That will make you lose around 10 centimeter comparing to the left radial. Depends on the patient height. Let's say patient is 5'8" to 6.0. I think on average, if you go right radial, you'll be able to reach iliac, common femoral, and approximal SFA, maybe the first 1/3. Of course, if you have a patient who are on the shorter range, I've had a case the other day, I was all the way distal SFA, right radial distal SFA. The patient was very short. But I think it's important to, when you start doing radial to peripheral, to kind of slowly understanding the anatomy, the complexity of the patient, where the lesion is. And I personally love to do a CTA beforehand. It gives me a lot of information, give me the calcification, the lesion location. So I would say common femoral, iliac, proximal SFA, most of the patient will be fine enough to use an E8 and deliver that.
Yeah, and certainly, as you mentioned earlier, from a patient satisfaction standpoint, being able to be done from the wrist and then be able to sit up right away and go home a lot sooner is a huge advantage. So, Sam, thanks again for showing us those terrific cases. I think they highlight elegantly all the wonderful new features of the E8 balloon, and I think folks are going to be very happy with this new addition to their IVL armamentarium. So thanks again for your time today.
Thank you for having me.